Senator.
Thank you, Mr. Chairman. Let us bow our heads in prayer. Dear Lord and Heavenly Father, as we have gathered here to do the nation's business, I seek your guidance and your blessings on the proceedings that are to follow. I ask that you guide our words and our thoughts and the deliberations as much as is possible. Thank you. Amen.
Amen. Thank you very much, Senator Rodriguez. The apologies for absence. Anyone? No? No apology? Okay. And we go now to the minutes, which you should have. We're going to take it page by page for any correction or otherwise. Page 1 is relatively straightforward. Page 2. Page 3. Page 4. Page 5. Six. 7. 8. 9. 10. 11. 12. And 13. Okay, can I ask for someone to move for the adoption? So moved, MP Tova Hamilton, and seconded Senator. All right, are there any matters arising? Just to say, colleagues, that we have 2 presentations, and so if there are matters related to those presentations, we may have the benefit of the presentation and then raise the issues. So one is a regular update, which the Chief Medical Officer, I told him to come in. Can we admit them in, please? Our Chief Medical Officer, Jacqueline Biseso McKenzie, and
yes.
The Permanent Secretary.
Chairman.
Yes.
I'm not certain exactly when the minute it is shown, but there was a commitment to the committee to have a representative from the private sector,
right,
vaccination task force here.
Right. So what happened?
At the next meeting.
What happened? Mr. Zaka was very prepared to be here last week, but because of a number of issues that were taking place, we had to push the meeting back a week, and it clashed with an appointment, a long-standing appointment that he had. So we will get him for the next meeting. He will be able to plan more with more certainty. Can you ask them to come in, please? Thank you. He was ready last week, well prepared, but then because of the postponement. So he apologizes to the committee, but he's very willing and ready to come and to participate. All right.
There are just 2 other matters, but the CMO would be the one who would be able to.
When the CMO presents. Okay, no problem.
I don't know when she presents, but I'd ask her if she wants to include in her presentation. Fine.
Oh, okay, fine. Okay, so we have Dr. Nadine Williams accompanying the CMO and the Permanent Secretary. All right, so you say you had a question for the CMO?
If I may, Minister. Thank you very much, Chairman. Last meeting we had a query CMO about the protocols in the hospital, the management protocols. And I had the occasion to speak to someone in senior position in one of your hospitals, and they said that they were not aware of a standardized protocol coming from the Ministry of Health in terms of management. That might just be an isolated case, but I am just recommending that, again, the ministry with its team sends that out to all the hospitals. That's for COVID management, that is. Send out to all the hospitals. And secondly, Minister, you indicated last meeting, Dr. Williams indicated that there was not sufficient data on ivermectin yet. Just to find out whether there is any new data and whether the Ministry of Health and Wellness could have an update on that. And I said to Minister, but this one is for you. You indicated in your press conference, and I want to get some clarity on it because it can be subjected to interpretation by whom, that the ministry, however, does not recommend ivermectin for the treatment of COVID-19, but distributors who might be interested in importing COVID-19 could apply to the Ministry of Health for approval for importation based on whatever. Can you clarify that? Because we do know that it is used in some cases in humans for other conditions, primarily in the veterinary world for some others. But if that is the case, and why is it an allowance that the ministry is making for importation of ivermectin, or what? I won't speculate, but I'd ask you to.
Okay, thank you. I think probably all three questions could be answered by the CMO and Dr. Williams. So let me ask them to just quickly deal with those, and then we can get into the presentation. CMO?
Right. Morning again, everyone. First of all, in terms of the clinical management protocols, they have been circulated. They are on our website, and those were one of the first protocols that have been put on the website. We do have regular meetings with our senior medical officers and with our medical officers of health. So we certainly will offer a reminder, since there is a concern that some persons may not have been exposed to the protocols. From the protocols were put out, the protocols would have been updated because, information has changed. So I think we have had 2 changes so far, and we continue to look at the new information that is coming out. There is a clinical management team that comprises specialists from across the island that are in charge of reviewing the protocols for clinical management. So we will circulate again. In terms of ivermectin, so what happens is that because we have not had a demand for ivermectin for human use in Jamaica, there's no preparation for human use currently registered in country. We do not have a problem to register ivermectin for human use for the unlabeled uses, because that is well documented in terms of its safety, its efficacy, and how it is recommended for usage. So we recognize, of course, that seeing the data out there, many physicians would, because people are looking for methods to treat, and they want to offer something, and they would have seen the studies that they would, in discussion with their patients, would want to try this drug. So we have no problem to register the drug, and in our discussions with our standards and regulations department, we have said that as soon as a request for registration of the drug comes in, we will expedite the process for registration so that the drug would be available in country. However, the recommendation for the registration is going to be for its unlabeled use. But we do know that as physicians, there are several drugs that we would have seen benefits, we would have seen small studies, and we would have utilized those drugs for off-label use with the consent of the patient and acceptance of responsibility. What there is that we don't have enough information on a policy level to say to the population that the benefits of this drug are clearly demonstrated, and the dosage that is, pardon?
COVID-19.
For COVID-19, and that the dosage has been tested and has been found to be effective in the management. I just want to remind the team that the first study that came out that had introduced ivermectin was a study out of Australia, where in the laboratory, the ivermectin was found to have antiviral properties against COVID management. However, the dosage at which that was found to be effective to have the plasma level is a dose that has not been studied in human beings. And so that is where the issue is, that those doses have not been found to be safe. So that's with the ivermectin. And the other issue was the, that was it? That was it, okay.
Okay, are you comfortable now? I think it's an important matter, so I appreciate the question because there is a lot of discussion in the country around this drug. What seems to be happening, and I think with some amount of understanding, we should understand and be sensitive to, is that there is a search for solutions around COVID. And there are a number of things placed on the drawing board that seems to offer some hope. As a ministry, we have to be guided by the clinical data, and it oftentimes doesn't meet the agreement or approval of many. But that clinical data extends to significant research outside of Jamaica, and even in the international space, you do find varying opinions. But ultimately, we have to come down on the side of being conservative in the approach, because clinicians' decisions impact lives, not just livelihoods, and that is a principle on which conservative approach is normally what is standard. All right, we have now Dr. Melody Ennis, who is in charge of the immunization program at the ministry. So we have the full team here. So in the interest of time, I'm going to ask members to allow for the update to take place. CMO will lead that. Immediately after, the PS, I think, will give a vaccine update, and then we open the floor for conversation. So just jot down your questions. Just allow them to complete, and then you just jot down your questions rather than stop them in mid-flight. All right, so CMO, you want to go ahead now, please? Are you controlling the slides? Okay, there's a gadget there. You can move it up and down, I think. Does it work? Yeah. Okay, go ahead, please. Turn on your mic.
Unfortunately, the slide set that we have up there now is actually the update from yesterday, the 15th. And it would show the numbers, it would reflect the numbers from the 14th, where we had, this is the 14th, right? I cannot even make it out so clearly. All right, so where it would have had 530, this is today's? Oh, okay. So it has been updated, and this is reflective of yesterday evening's numbers. So we're seeing that we had 530 PCR positive out of a total test done of 1,763. And we had also antigen positive from the private sector. We had 37, or 32, and 40 from the public sector. So overall, a total of 602 positives. And in terms of deaths, 494 deaths were reported, the case fatality rate of 1.5% presently. Next slide. This is the age group distribution, where we have, you can see for the different age groups, the highest incidence is among the 20 to 29 age group, and followed by the 30 to 39 age group. So that is the age group that we have the most numbers of cases. But just to say that in discussion with the EPI team, when we look closely at the 10 to 19 age group, when you actually do break that down into smaller groups, we have found that at the end, the older persons between the 18 to 19, that is where you are also seeing a high number of cases as well. So overall, the 10 to 19 is at 7.4%, but when we break that down, you do find that the older persons in this age group, there's a high incidence. In terms of the age distribution for the COVID-19 deaths, again, to show that this is where the vulnerable groups lie, in the over 60, where 60 to 69, 70 to 79, and 80 to 89, greater than 90, we have the highest case fatality rates, the highest percentage of deaths in those age groups. Male-female distribution, still the females, 56.1%. No, this is the overall sex distribution. Females more than males, 56.1%, males 43.9%. And in terms of the case fatality, the deaths, males at 55.1% and females at 44.9%. In terms of the risk factors, comorbidities, and the COVID-19 outcomes, we've had 99% of COVID-19 related deaths had one or more comorbidity or risk factor. 73% were 60 years and older, 55% with cardiovascular disease, 41% with diabetes mellitus, and 12% with chronic renal disease. So these are the areas that we're finding that we have the most poor outcomes. 6 or 1% of COVID-19 related deaths had no known comorbidity or risk factor, with an age range in 36 to 54 years. We had taken a look at the poverty and COVID-19 outcome, and what we found was that in looking at the three thirds, the poverty line tertiles, for the second and the third level, where in the second level where you have 9.1 to 19.5% of homes below the poverty line, and in the third group where you have 19.6 to 71.9% of persons below the poverty line, those groups had an approximately 1.5 times more chance of having deaths than the group, which is the level 1 group, where you had 0 to 9% of persons below the poverty line. So it certainly suggests that there is a vulnerability that is associated with the poorer persons or the poorer communities, because it is really linked to community. Next. In terms of the epidemiological curve, this is the cases by the date of symptom onset. You will see that our trajectory is still heading upwards. So we have not yet seen a plateauing of the number of cases. We would have instituted several measures or enhanced those measures. What we have found in the past, that after the introduction of more restriction, it does take about 3 to 4 weeks before we do see the effect of that. Next. And that is borne out in terms of what's happening with the reproductive rate, because at the start, when we introduced those measures, the reproductive rate was at 1.3. The reproductive rate now is estimated at 1.1. So we can see that it is slowly going down, meaning that we should see an effect of that within about 3 to 4 weeks' time, where we should see, if this continues to trend downwards, that there would be a decrease in numbers. And this gives you a table that gives you that kind of projection using a reproductive rate of, let's start at where we are now, at 1.1. If it is that we have 617 cases, then based on the exposure that we expect that each person would be able to pass on to 1.1 person or over 1 person, then in another 4 weeks or 2 incubation periods, we would expect to see about 994 persons affected. However, if our reproductive rate falls to, say, 0.8, that 617 persons affected now would be transmitting to less persons, meaning that if persons adhere to the restrictions and they stay home, so it decreases their chance of exposing other persons, then the reproductive rate would fall and go below 1, so one person would not now be exposing and infecting another person, and we would expect that our numbers would fall to approximately 202 in a month's time. This is a picture of our weekly positivity rate. Now, from our weekly positivity rate, the last figure represents the week so far. And so we would only have 2 days there, and the average for the week would be by Saturday, we would have that number and we would see exactly where we are, where that number is concerned. We find that usually at the beginning of the week it starts out high, but by the time you average the entire week, it may fall a little bit. So for the last 2 weeks prior to this, we would have seen what could have looked like a plateauing, and we would see what happens for the rest of this week if that trend continues. But right now, you will see that line is going up, and as I said, we will watch this and see what happens by the end of the week. Now, you will see that there is the line separates into 2, and just to give you a brief explanation of that, to say that we use a corrected positivity rate, and persons might have heard that before and wondered what this is about. We use the positivity rate based on the PCR test and the tests that are done, the antigen tests that are done in the public sector. This is simply because the negatives for those cases for the antigen testing would have gone to PCR testing. We know that for the antigen testing, there could be a high false negative result, and so therefore it is important to go on to PCR testing, and especially where we're testing in the private sector, and that testing is not really choosing the most suitable person for antigen testing because it is testing asymptomatic persons mostly, and so therefore you're going to have a high false negative rate because you may have persons that are pre-symptomatic or persons who have at this point a low viral load, and so they test negative. So because those do not go on to PCR testing for confirmation, we would not include them in determining the overall positivity rate for the country. So we utilize the PCR positives as well as the public sector antigen positives. This gives us the burden of COVID-19 in Jamaica by week, and the red line is looking at the deaths. So as you have seen that our positivity rate, which is in blue, which is in yellow, right? As the positivity rate has increased, you would notice that our hospitalizations have increased, and also we would have seen that the number of deaths have increased. That drop at the end of the graph, we would have to wait to see if the actual numbers for that changes over time, because we would find that the deaths tend to follow maybe about 2 weeks later. So you may find that now it is down because we don't have the deaths being reported for that time period as yet, because it is also by the time of death and not necessarily when it is reported. In terms of hospitalizations, we do continue to see that there is a burden on the hospitals. Since December, we would have seen that the number of admissions, the average number of admissions per day has steadily increased, where we would have had about 25 admissions per day for December, and now we are up at 60-something for last week, and it has just been steadily increasing in terms of the number of admissions. This week, I have noticed that we have been in the 50s, and so again, to watch to see if that is a plateauing, too early to say. In terms of the actual numbers of persons that are in beds, that persons that are occupying the beds that are reserved for confirmed cases as well as the suspected cases, we have also seen a constant rise, where yesterday we reached our highest level where we had 700 beds that were occupied. What it means is that we have some persons that are also on the general wards because we don't have space enough on the COVID wards, and so we have to be making alternate arrangements in terms of how to separate those patients and to keep the risk of exposure low. So you will see that the isolation capacity right across the country in all the regions, there would have been several of the hospitals that would have been, our alert level is above 85%, and then of course many of them are over 85%, and quite a few over 100% occupancy. Next slide. Okay, so I think we could stop. That's the last slide, yes. And we could stop here. So
okay, thank you very much. Can we go on to the next presentation quickly? Who's uploading it? Which is the vaccine presentation. We've been joined since CMO started by Dr. Webster Carr. She is our chief epidemiologist, so she puts a lot of these, what should I call them, charts and graphs and strange looking stuff together to explain the trends of the virus and some of the interventions that we have implemented, but very important part of the tracking and the analysis and subsequent policy action. Are we working on putting up the next slide? Oh, he's going to do it? Oh, he's not hearing? In the meantime, then, let's not waste time. You want to have a quick question, and then as soon as it's up, we can start.
Thank you. Just,
go ahead,
just needed some clarification. CMO, you're saying that over 60 is a comorbid condition.
It's a risk factor.
The risk factor. Mm-hmm. Oh, okay. Because you indicated in the slide that 73% are over 60, 55% have chronic hypertension, and 41% diabetes. So it's a risk factor. Fine. Mm-hmm. And the other one, it says 700 beds yesterday occupied. Is that 700 patients hospitalized?
Hospitalized.
Okay. Mm-hmm. So yesterday you had 370
confirmed cases.
Confirmed cases.
Right. So what would be on the
366 number hospitalized. Is that a subset of the cases, or those are only the confirmed cases?
Confirmed cases.
So within the 700 now, you don't know the
So we would
status.
have suspected cases,
Mm-hmm.
and
yes.
But they would have to be treated in a way that they are pretty
Just
much
in case
isolated.
Right.
Yeah. So those would have been occupy the beds that are reserved for the confirmed and the suspected cases.
Yeah, but the point I want to know is that in your daily reporting on your website, the number of hospitalization is only reflective of those who are hospitalized and confirmed.
Confirmed.
Okay.
Presentation is up, so I'm going to ask the, is it you who are presenting, PS? PS Brand. Let's go right into it, and then we'll have a discussion.
Thank you, Chairman and members. The presentation will be made jointly between myself and Dr. Melody Ennis, who is the clinical lead for the COVID-19 vaccine implementation program. So overall, So overall, we have vaccinated approximately 14,650 persons to date. Of that, that is 84% of the target for week 1. It's 30% of the target for month 1, and we have vaccinated 1% of the target for year 1, which is 65% of the population. When we look at the planned versus actual, we are recognizing that overall we are averaging at about 84% of the plan versus actual. So we are seeing where on some days we are ahead of target, and on other days we are at target. When we do the separation by gender, 55% of the persons vaccinated between the 10th to 15th of March are females, and 45% are males. However, when we look at the distribution by age, we recognize that the majority of the persons vaccinated fall within the age group 30 to 69 years old. And that is primarily because we are vaccinating the JDF, the JCF, and health workers. So we see, for example, in the 0 to 19 age group, about 66 persons. That would represent some persons who are recruits are new entrants to the JDF and JCF, or they may be healthcare workers that work in non-clinical areas like administration within the facilities. They may be security officers or porters.
Yes, if you could, the age grouping along the side is very blurred from where we are.
So
we cannot see.
So we start from 90 and above. My apologies. So we start from 90 and above. Then we go 80 to 90 below that. So 90 and above is 41. We have 80 to 90, 70 to 79, 60 to 69, 50 to 59, 40 to 49, 30 to 39, 20 to 29, and 0 to 19.
Okay.
When we do the distribution by parish, we recognize that our population centers represent the largest numbers of persons vaccinated. So we see Kingston and St. Andrew, St. Catherine, St. James, and St. Anne with the largest numbers of persons vaccinated across the island. When we do the disaggregation by region, in terms of the target for the days that we have completed vaccination so far and the actual achievement, we recognize that the regions on a whole are meeting their targets of numbers of persons vaccinated in the categories of persons to be vaccinated. When we look at healthcare workers, a total of approximately 9,781 healthcare workers have been vaccinated. The target for healthcare workers is approximately 15,000 healthcare workers to be vaccinated. So and this was 15,000 by the end of March. And as at the 15th of March, we would have completed over 70% of the population of healthcare workers. Some elderly persons have been vaccinated within the program to date. So when we do the disaggregation, 67% of the persons vaccinated are healthcare workers, 24% are persons in the JDF, JCF, and 9% are elderly. I'll ask Dr. Ennis to speak to the surveys, of which there are 16.
Thank you very much, P.S. Brian. We have been tracking persons who have presented with symptoms post being vaccinated. We gave a listing to persons of the things that were normal or the normal side effects that one could experience once they have received the vaccines. So the ones that were expected included dizziness, some amount of flu-like symptoms, pain at the injection site, fever, chills, and some vomiting in some cases. So most of the persons that have reported having had an adverse event fell into these categories. What we have been noticing is that the younger persons, which would include our healthcare workers, those below the age of 60, they actually seem to have more of these side effects than the older persons. The older persons over 65 getting the vaccine seem to be quite fit as a fiddle, but the younger ones tend to be getting the flu-like illness. This has lasted for just about 3 days. I have a report of just 2 persons that it went on for 72 hours. But for the most part, it's flu-like illness, chills, headache. A few persons made the comment that the fatigue was just so much. But once they got a good night's sleep post the day of vaccination, then they recovered within 48 hours. So those are the events that we have been tracking to date, and we continue to monitor and to advise persons who receive the vaccines that these are normal side effects that actually tells the body that it's doing what it's supposed to do, develop antibodies. Thank you.
This slide has come out very badly, but this is our current projections on supply. So we would have noted in the public domain that we received our donation of 50,000, and yesterday we got the first installment of our COVAX allocation of 14,400. We have received notification from COVAX that we are to receive a second allocation from our allotment of 26,800. The anticipated delivery time for that is the first week of April. We have a discussion that has not yet been finalized, but the projections on this allocation through the private sector engagement with the NHF is that an allocation of 100,000 doses will be available in the second week of April. But then this is still about 70% guaranteed. The fourth installment of our supply side, or the fifth installment, is our projections from the African Medical Supply Platform of 500,000 doses of vaccine. We are still projected to receive that allocation in April. And then we have our allocation that is still being programmed in May for Moderna. And then the final allocation of 83,600 from our COVAX for this quarter is anticipated in the third week of May. Excuse me, all things being equal. So that represents a downward projection for this quarter of approximately 100,000 vaccines from our previous projection of 974,000 vaccines for this quarter. So we had projected an additional 100,000 that has not materialized in the month of March. I'll now ask the CMO to give an update on COVAX.
So this is this is the COVAX update that was presented on the 15th of March. And to note, the approval for the Johnson & Johnson vaccine was given on the 12th of March, and so that now becomes part of the COVAX offerings. And so perhaps in our second allocation, what PS has just described would be our first allocation through COVAX, and our second allocation is expected in the second half of the year. So we would expect that we would be getting some Johnson & Johnson vaccine in that, or even perhaps in the next batches of this allocation. We wait to see, but certainly Johnson & Johnson is now part of the arsenal that COVAX has. It has been approved. Next slide. So importantly, they had put in their update that in addition, COVID-19 vaccines developed by Sinovac and Sinopharm are being reviewed for emergency use by the WHO, and decisions are expected later in this month. So if those do in fact get emergency use listing, then by the end of March, then that will also increase what is available through COVAX, and also, of course, any bilaterals that we have or are negotiating. This would be a big plus for that. Next slide. In terms of this, are very you're not able to see very clearly, but this is a status update that was put up on the WHO website as of the 10th of March that shows the progression of the vaccines, and anybody is able to access this information just by Googling the WHO status update for vaccines, and you'd have access to this information. It is updated periodically to tell you where in the process the vaccines are. And this does show that the Sinopharm and Sinovac vaccine it is expected by earliest March that those would complete the process. Importantly, we've heard a lot about the Sputnik vaccine, and on this chart, it does say that they still are awaiting a lot of the data to come off, and there's no date that is given, but we do know that Sputnik has completed their phase 3 clinical trials, and they have been issuing data as they get it to the WHO. So that's what we see here as rolling data being assessed, meaning that when everything is completed, they would not all submit it at once, which would prolong the assessment period. But as the data is being summarized from the trials, it is submitted and there's ongoing assessment. So despite that there's no date yet given for the Sputnik vaccine, we do expect that there will be a ready assessment, once everything is submitted. So that's where I think those are the vaccines that the others, a few other vaccines from China that's still waiting information, but is on the chart. But just to note that I think we have 81 vaccines that are overall in clinical trials still, and over 180 that are in preclinical trials. So over the year, we do expect that more vaccines will become available or be more advanced in the trials.
So thank you very much, CMO. Chairman, I just want to remind the committee of the phased approach to implementation and our target of 65% of the population by March 31, 2022. Now, in phase 1, we have our healthcare workers, the elderly, the Jamaica Defense Force, the Jamaica Fire Brigade, Jamaica Constabulary Force, government officials, schools, Department of Correctional Services, PICA, Jamaica Customs Agency. So phase 1 implementation has begun, and we started with our healthcare workers, our elderly, Jamaica Constabulary Force, and Jamaica Defense Force. We have sought, though, to further do sub-prioritization based on this group. Right. So, in this week, week beginning March 15, we will be continuing the healthcare worker, JCF, and the JDF. Then we have started today the vaccination of the cabinet, members of parliament, senators, and heads of ministries, departments, and agencies, but only those persons 60 years and above. We now also will start this week the elderly in state care that are in infirmaries and the employees in those infirmaries, as well as elderly persons in private homes, private nursing homes, I should put that, nursing homes, and the employees in those private nursing homes. On Monday, the 22nd, we will launch our web portal for the scheduling and appointment and registration of persons for vaccines. And once we start that process on Monday, the week of Monday the 22nd and 28th, we will be vaccinating our parish council persons 60 years and above, and we will begin our elderly 75 and above. So persons who are 75 years and above will be required to engage the software. They will be also able, and I'll walk through that process. The week of March 29 to April 4, we continue with the elderly 75 and above. And then we move from there into the wider elderly group, 60 years and above, depending on the supply of vaccines in the week of April 5 to 11. Now, this entire prioritization process, our sub-prioritization process that we have outlined here, is dependent on the supply of vaccines. So once our supply matrix changes, this prioritization will change. So the appointment system will begin with persons. So there will be a public announcement of the appointment system and its launch. And persons will be able to call in. Persons will be able to be registered by the parish health department. Persons will be able to register using a website, or persons can engage their private practitioner, their private doctors, to make appointments for them. Once they have engaged the system, they will be prioritized. And the prioritization, as I pointed out, is on the phase basis. So if you are not in that phase, the system will not give you an opportunity to make an appointment. If you are not in the prioritized group, meaning if you are not 75 and above, at this point in time for the first couple of weeks, you will not be given an opportunity to make an appointment. And as we move through the different prioritization schedules, you will not be able to, you'll be able to make the appointment at the time. Once you are prioritized and you have received their notification of prioritization, the system will send you a message either by text or email, or you'll be called by the call center that we are engaging. So if you do not have a cell phone, but you have made an appointment, or you have, if you indicate when you are making the registration that you do not have a number, a method of reaching out to you will be established either through our community health aid, our parish office, or we will have our mechanism with the call center to make a call to you. Now, because of our scarcity, each appointment is linked to a dose. So if the dose disappears, the appointment disappears. And that's a function of us managing. Well, when I get to the question, Alex, I'll show you. All right. So, and this is primarily members because we now have 64 guaranteed vaccines in our arsenal. 64,000. However, if a vial drops and breaks, each vial contains approximately 10 doses. So we are taking every effort, or making every effort to protect the vials. But if any human error should creep in and one of those vials break, then even if we have made the appointment, at the point of the appointment, we wouldn't have the vial. So that is why we have to put in the control mechanism that allows us to match vial to person vaccinated. So that's the end of my presentation, Chairman. And we are available for questions.
Thank you very much. The team, a number of persons presented, so thanks to the team, all except Dr. Nadine Williams, who I'm sure will at some point provide some information. So there you have it, colleagues, and those listening online. There are two presentations giving the update. Just to summarize quickly, we are still experiencing a surge, but at a slower pace, or a reduced rate of increase, with moving from a 1.3 productivity rate, which has been the cause of the massive expansion, each person infecting 1.3 others, to closer to a 1.1, which shows a trend in the right direction. We believe that some of the restrictions have played an important role and the continuation of the messaging. Our death rate will, we believe, follow that trajectory. And just to say, nationally, we have a 1.6% of infections. Up to yesterday, I was told, 1.6% death rate. 1.5 today. And to put in context with global figures or benchmark, the world is experiencing approximately a 2.2% of all confirmed cases. So we're still doing fairly better than the rest of the world in terms of the averages, but every death is regrettable, of course. Hospitalization remains a significant challenge, and there are many reasons for this, but primarily it is about the numbers that are being infected. And once that number goes up, then a percentage of that ends up in the hospital system, and the system is under stress, which accounts for things like oxygen being in short supply, beds being in short supply. When you hear of a hospital like Cornwall with 148% occupancy, all it means is that the COVID ward is full, and we have to transition other regular wards to become COVID wards. So it means more than what was planned for. The two field hospitals that have been set up, we still have some capacity there, but it is being maxed out by the day, given the numbers that require hospital care. And the field hospital that is being relocated to Spanish Town, this is the one that was donated by the U.S. Government, is close to completion and should be able to take some capacity should the need arise. The relocation was because of the high case numbers in St. Catherine. On the report on vaccines, I just want to say that, I really want to say for the record here at this committee in the Parliament that the team has done well over the last 5-6 days. We're a week tomorrow. I really want to commend the work of those who have put the plan in place. We've all brainstormed on it, of course, Cabinet approved, led by the PS, CMO, and the other team members here. The regional authorities who are substantially responsible for implementation. I've been through 5 parishes over 3 days last week, leading into the weekend. And the infrastructure is up, not always perfect, because we don't have buildings waiting on these things. So sometimes it's a tent, sometimes it's a makeshift room that you convert, but you can see the commitment of the team, the medical personnel in the field, who are committed to the cause and who are doing a lot to achieve the objectives of the plan. And today, with 14,000 plus inoculations, tomorrow, I suspect that will go up. It will go up because we're doing work today. We will close the week, I believe, well over 85%, perhaps even closer to 90%. I think that is an admirable achievement, given that this is the first week, and we expected that we would have a few issues, because this is how it is. It's a start of a process that is going to last the better part of a year, and therefore we have to learn in the early stages, but it will get better with time. So I want to commend the team, and I want to say it to the public and to this committee. We are learning as we go along, and to the extent that there may have been some issues, we correct those issues. Also want to say for the record, because I know the question was asked by my colleague, well, not by you, but by the leader of the opposition, who is still a colleague in the Parliament, and rightfully so, understandably so, about an audit, that part of the vaccine plan requires an audit, and that audit is in fact taking place as we speak. So in relations to how much vaccines have been administered, the vial, the waste, and that sort of thing, some of that data went up here today. The PS put up on the presentation. There'll be more information around that. So we appreciate the call, and we appreciate why it was made. But just to say that it is already fixed in the plan for that audit to be ongoing, and not necessarily to determine deviant behavior, even though that may turn up, but to also improve the efficiency of the program. It is important that we audit the program to determine where we need to improve transaction time and cost, because ultimately that's what determines efficiency, managing transaction time and cost. I want to close by saying that today we launched a very important aspect of the private sector collaboration, which was the UNICEF software platform for appointments, which will be launched next week. The private sector vaccine initiative supported the ministry in helping to assess and to determine on that platform. There were a number of potential possibilities, a few. That went to Cabinet and was approved. That is now being fine-tuned to be launched when we move to general population. The UNICEF, it's a UNICEF software, UNICEF-administered software.
I heard that, Minister, but there was the talk in the private sector that they're assisting the government with the software. Is it the same one that you're referring to?
Yes.
Okay.
Yes, the same private sector vaccine initiative, which is a combination of PSOJ, Chamber, and Jamaica manufacturers and exporters. That we signed the agreement today. Cabinet has approved it. And in addition to that, the private sector contributed some $11 million worth of tablets and keypads with protection screen that will be used as the hardware to upload the information across the centers. I raise that here again to say it's a demonstration of how partnerships can work, and wherever there was suspicion around the MOU, because I know it was raised, the private sector member will be here next meeting. Unfortunately, he had a clash this week, but I think it's an indication that we can benefit as a whole if we put our heads together to move the process forward. All right, so that's my introduction. So we start with Senator Campbell Rodriguez, then I'll come to you.
No, just before you go to the Senate, and if you'll allow me, I just want to make it clear in my own mind that the PSOJ, the private sector, whichever one it includes, the assisting with the software development or management or whatever it's being called, it is using the UNICEF platform.
Right.
They're not two different.
No. It's the same, and they like to refer to themselves as the private sector vaccine initiative, not the PSOJ, because they have several private sector groups. But it is. When we get to that point, if you want, I can ask Dr. Ennis to comment on it because she has been working closely with that group. So let's start with Senator Campbell Rodriguez, and then I could go on to you, member, and then, right.
Thank you, Mr. Chairman. Let me just say for the record, thank you to yourself and the team at the Ministry of Health for all the hard work. I know this week was probably hardest for you last week because you got so much flack from the public. But let me just say, most of us have, as Jamaicans, appreciate the work that you're doing and understand that with new processes, there will be glitches, there will be problems, but we know you're going to wheel and come again, and it's going to be perfect. So thank you so much. So let me just state that first. P.S., you mentioned in your presentation that when people are signing up on the new system, if you are not in the phase that is being currently run, you won't be able to make an appointment. Why do we not allow, because to get the information out as each phase starts can be problematic because there's so much information going out. Can the system not be set up that whether or not your phase is currently taking place, you can register? We know you wouldn't register for the vaccine, say, during this phase, but in the future. Is that something that could be considered? That's my first question. Second question is, coming in at the airport, I noticed that we're not tracking anymore on the phones. And I'm wondering, so people just come in without anyone, before you had to download something on your phone, you were called, you had to, scan yourself, all of that. That doesn't seem to be happening anymore. It wasn't a few weeks ago. Why is that so, and is it something that we're looking to put back? And then thirdly, and this one is very personal to me, the tax offices in Jamaica. I am convinced that the tax offices are a hotbed for COVID in Jamaica. How do we come up with a plan to prevent that crowding that we see at the door of all of them except the one on Constant Spring Road? How do we solve that issue? Because at any one time, you have at least 50 persons bundled and one security guard trying to control that crowd, which is impossible. So just those are my questions.
Thank you, Chairman. So on the first question around the appointments, because there's scarcity, right, you really have to manage the appointments, because I could give you, so right now, I have certainty around 64,000 vaccines, because they're in Ireland, I have them in hand. Anything outside of that have an element of certainty, some greater than others. Therefore, my ability to inoculate is upon that certainty. So if I give you an appointment outside of 64,000, Yeah. So if I give you an appointment that says April 20 or April 9, and then April 9 comes, I'm going to have to cancel because I wouldn't have the vial. So what we're trying to do is to ration, and that's a very bad word when it comes to immunization, but that's a reality across the world for vaccines, except in some metropoles. But within the context of developing economies like ours, there is a rationing that takes place. And so the prioritization, the strategy behind the prioritization is around the vulnerable and the risk factors associated with vulnerability. And so we look at the elderly. And so we recognize, as presented by the CMO, that 75 and over, you have a higher mortality rate, a higher vulnerability to adverse outcome from infection. So we need to prioritize that group. So we start with that group. And then when that supply side is complete, once we get more supply, we move to the next set of priority group, which will be the 60 and over. And as we replenish our supply side, we create that match between demand and supply to allow us to make those appointments.
Can I suggest that you make that public proactively, because some people may create mischief around it, while it is a very simple explanation that makes so much sense. But to prevent that conversation going down the wrong road, if we make that the reason the system is set up that way is because of scarcity and matching, then I think it would save us a lot of drama in the public sphere.
So on the question, Chairman, of the tracking by phones, we are not aware that that program has been suspended.
Stopped for a few months now.
Right. So it was brought to my attention just this week when a healthcare worker traversed the system and said, "What's happening? We're not feeling the presence." So I've actually instructed our the International Health Regulations Unit to review the process that's happening at the airport and just to be there for a few days to see what it is that we need to do. Because while we do not want to go back to a system where there's just this overwhelming presence and congestion at the airport, we want to ensure that starting with the message that persons receive once they're on the plane, that is concrete. Persons understand what is to be done and how it is that we are going to be managing, because everything now is online. Everything that was lined up that people were at desks doing, that has all been pushed to before you come in, everything is online. But we do want to ensure that persons are aware of the restrictions in place. And so we're doing a review right now just to see what else can we do to ensure that that presence is still felt.
And then the last question on the tax office, we will have to have conversations with the Ministry of Finance and Tax Administration in Jamaica to see how we can facilitate support to streamlining their process. All right.
Okay, thank you. Member?
Thank you, Chairman. I have a whole series of questions, so I'm going to ask the respective presenter to make note and after.
So remember now that...
No, you have a time constraint, then I'm going quickly. The presentation, CMO, with the tercile of the poorest are the ones with the greatest number of deaths. Is it a case that in this grouping, people seek medical attention late? Is it a reflection of what happens in the system? You know, in a certain era, they said death is the grand leveler, but COVID-19 now seems to be it in terms of putting everybody on the same pattern. So why are we seeing greater deaths in this tercile of those below the poverty line? Secondly, why is not the public sector positive the private sector positive antigen tests included in the numbers? You did indicate that's only the public sector antigen tests that are included in the numbers. PSU showed us a pie chart of those persons who got vaccinated. It would have been, if the audit could reveal and demonstrate to us, could also tell us those who broke the line in that grouping, because you had the healthcare workers, you had the constabulary and the Jamaica Defense Force, and you had the elderly. You made mention when Senator Rodriguez Campbell asked a question about the 60, and you mentioned that you have 64,000. Do you actually have 64,000, or you have vaccines for 32,000 persons? Has a decision been taken to give all 64,000, or you are, understand, but there are two thoughts. One, whether the country should give the 64,000 and wait the other 64, 8 to 12 weeks afterwards, or 8 weeks as we are now proposing, or you are reserving that half of the 32,000 goes now and you keep the others for the next 8 weeks. Dr. Ennis, welcome to your first meeting here at the committee. You mentioned about the ISAVI. Can you say if that captures the side effects at the vaccination sites, or it is people reporting post-vaccination, because there's really no formal plan in place, there's no formal advisory to the persons who get vaccine that they may report any effect. And could you also, in answering, tell us what are the side effects that are included in this, this grouping? Minister, you indicated, well, the team indicated at the PS that 500,000 under the African Medical Supply Platform will be around the 4th week in April. This is an expectation, but as the PS alluded to, and as was said yesterday in some media thing, that that particular program is awaiting some legal hurdles to cross. How expectant are we of that on the 4th of April? And CMO, could you, for my own purpose, indicate is it all the vaccines that are approved by WHO, given emergency use authorization, automatically fit under the COVAX facility? And why I ask this question, you referred us to a particular website, and we see that there's one AstraZeneca, which in terms of a dossier accepted for review, accepted court date of AstraZeneca, and it says non-COVAX, and data for COVAX expected in March 2021, and anticipated decision date. Now, you also mentioned about Sputnik and the two Chinese ones, and you mentioned automatically that they would go into COVAX. The question is, does all those that are approved by the WHO automatically in the COVAX facility? And we have not in all of this team mentioned anything about how do we treat persons living with disabilities. And the question that also arises is, what about those persons who would not be able to give informed consent? Those persons who are on the streets, who will interface with people all along. How do we treat this particular grouping of persons in the community? Because we have been silent so far in terms of how they are addressed. We have spoken to those who are in nursing homes and care facilities, but not those on the street. And it would be good, as the Senator asked a while ago, so that the country can know what is basically happening, if we could give some update on this. Thank you.
Thank you, member. So you have asked about 10 questions. 11, sorry, to be exact. So for the benefit of the other members who have questions, I'm going to ask the team to be very succinct and just go quickly without much elaboration so we can give others a chance. Starting with me, I'm going to refer the African Medical Platform to the PS or CMO, who will give a better understanding of what's happening. All right, so you want to start, CMO? PS, you go ahead quickly. Keep it brief, please. Thank you.
Thank you, Chairman. So with regards to the African Medical Supply Platform, it is indeed correct that we are still awaiting the legal documentation from them in terms of the contract for supply. Our indication from the African Medical Supply Platform is that this document should be with us this week, and that there is a 4 to 6 weeks delivery once signed. That is the indication from them, and that is why we have the projection to the end of April for delivery. So the 4th week is where we are projecting to for delivery once we receive the contract this week. But I want to make the point, not to elaborate, Chairman, but to make the point that the market for vaccines are so fragile, and there's so many moving parts around the access to the market in one instance, and then even when you do access the market and have a live contract, the changing dynamics of that market. For example, we are told in one instance where a manufacturer commits to manufacturing vaccines and commits to supply. However, the inputs or the raw material for making the vaccine is unavailable, and so they have to change their supply structure, and therefore it changes the vaccine programs in country. So nothing that outside of what I have in my hand is sure. It's not until it lands at that airport and we have it in the hand that we are sure. So just to make that point. Now, in terms of the question around other persons outside of the priority groups and whether or not we have persons outside of the priority group that received the vaccination, the answer is yes. In the first days of operation, the instruction to the clinical team was, in order not to waste a vial or waste a dose, if you had completed the persons that were before you, and you had a dose, if you had a dose, then you should just apply it to the nearest person who was willing to take it. Because the lifespan of the vial, once you pierce it, is 6 hours. And so in order not to waste it, you then had to find someone in close proximity to do it. Now, those instructions have been adjusted, where we are now...
Yes, I was really talking about the bomb rush, not talking about that particular part, because that is wound up in the explanation you're giving, but not separate.
No, let me understand then.
There are instances, like at National Chest Hospital, at the comprehensive clinic, where people who had no groupings, no situation in any of these groupings, got vaccination, right? And that is what the audit that the minister is telling us is to be done, not only to find those who were the breakers of the line, but also for administrative purposes. That was what I was asking. So what about those persons who were neither in these groups? Because we understand the need to not waste any of the vaccine. That's the only thing I'm asking.
What are you asking about those persons?
No. When I was saying to the PS that in his pie chart, indicated all those who were elderly, those who were in the security forces, and those who were in the healthcare workers. But he did not make any mention of those who got vaccines who were not supposed to have gotten within that grouping. He's explaining that the concept of not wasting the 9th or the 10th dose. But what I was actually referring to were those persons. Has your audit so far indicated?
What are you asking him to do? To name them or number them?
No. Numbers. Just numbers.
Numbers. Right. Well, I would imagine that they're all in those numbers that have been placed there.
Right. Overall, in terms of those persons who in the first days would have gotten vaccines outside of the, it's less than 100. It's less than 100. Outside of the specific groups, it's less than 100.
And let me just say, Member, just to be clear, that I don't think the process should be condemned, and I don't understand you to be doing that. But I have noticed significant criticisms of the process in the early aftermath of the first and second days. The truth is, there was an expectation that we would have some of these mishaps. The issue was how quickly we responded and sort of adjusted to ensure that we regularize the situation while learning from it. My understanding at Chest Hospital was that the system was shut down when there was a rush on the location. The rush on the location was primarily due to persons calling other persons, and there was a view in the public space, and certainly with those who were called, that once they got there, they would get through. So you ended up with a crowd. The system was shut down for a while until we sorted that out. As it relates to the St. Joseph's Hospital, that facility was primarily to serve private physicians, and I think private nurses, if I'm not mistaken. So it was for the private sector, frontline worker, health worker. To be totally frank, which I try to be normally, yes, I have to say that. To be totally frank, many of them turned up and brought with them their significant other, their caregiver, or their very close friend. Now, member, colleagues, do I need to expand on that? So there was an issue because the region, Sarah, had made contact with more persons than we had planned for that day, including medical students doing clinical rotation who were entitled because they are in the hospital system. And they represented a fairly significant number, and they ended up there. At one stage, the St. Joseph Hospital had about 400 or 500 people waiting. There was this argument about uptowners and so on. I see it floating around in the space. We tend to lock on to every rumor as truth, but the truth is, because we were serving private practitioners, and you being one of them will know that you're not doing too badly as a private practitioner. So you come to a location and you see a lot of not so inexpensive cars, persons who are in line. There's an impression that is formed that it is an uptown crowd. And the truth is that category of persons who were being served at that time would create that impression, but that facility was specifically for the private sector physicians, and that led to some issues which we had to deal with over time. I don't know that we had any significant challenges in the other locations. I'm sure we had a few challenges, but generally speaking, I think we were able to correct those and are now trying to get back on track. Can you respond to the other 9 questions, please?
So, Chairman, after you were so succinct, I will turn over to Dr. Ennis to speak on the decision to inoculate using first dose with the supply that we have.
Thank you very much, PS, and thanks for your kind words, sir. We have made contact with the Pan American Health Organization just to ensure that we can give AstraZeneca vaccines from different manufacturers and it does not cause a problem. And the answer to that is yes. So we will be vaccinating the 64,000, and yes, because they can get another AstraZeneca from a different manufacturer. So we have ensured that that is so. I can just continue to go on with the other questions that I would like to answer. With regards to ISAVIs, yes, so we have the listing, and indeed, sir, on the back of the vaccination card is the instruction, if you have any challenges at all, that you need to contact said facility where you receive same and make a report to the nurse or the medical officer in charge. So that is there. There is also the leaflet that persons get when they are vaccinated. Unfortunately, though, you know, we're not much of a reading society, so persons have it and they don't read, and all the side effects are there on it. So we are looking to put in the public space just little ads, cartoons, if you will, that will tell persons exactly what are the things they are to look out for. So we have 3 groupings of side effects. We have the very common ones that will affect more than 1 in 10 persons, which includes the tenderness at the injection site, just a general feeling of fatigue and being unwell, headache and nausea. And then we have those that will occur 1 in 10, common ones, which includes the lump at the injection site, vomiting, flu-like illness. And then we have the less common ones, 1 in 100, that includes the feeling of being dizzy, decreased appetite, some amount of abdominal pain and sweating. All of the above usually disappears within 24 to 48 hours, may last for 72. With regards to the disabled and the homeless populations, so we have been working closely with the JCPD, the Ministry of Labor and Social Security, as well as a group that actually knows the whereabouts of the homeless, and we're going to be partnering with them to address and vaccinate these persons. Now, I want to hope that we will indeed get Johnson & Johnson vaccine quickly, because that's the 1 dose, and I believe this very vulnerable population would benefit from a 1 dose, especially the homeless when we catch them, you know, and we don't want to scare them, you know, they're going to hide in. So we would hope to get the Johnson & Johnson to be able to give them 1 dose. Yes, sir, I believe I have answered most of my questions.
Okay, can we go on now to Senator Longmore, Dr. Longmore, and then we go to 2 others. Okay, Dr. Webster, quickly.
Okay, thank you. Good morning. Good morning. With respect to whether we know why the person died in the lower 2 tertiles, we have not done that yet. So what we have done is we did a neighborhood assignment for each person based on where you live. And we ran a logistic regression on that. So we have not done the deep dive into these yet. So with time, we'll get more information. With respect to the private sector antigen testing, all positives are included in the numbers, and in the calculation of the infection rate, but they are not used for the positivity rate because it would give us a false sense of security, or it would seem that our numbers are going down when they are not. Thank you.
Thank you. Can we go now to...
Oh, there's one last question, Minister, concerning whether all the vaccines that are on the emergency use listing will be available through COVAX. No, it doesn't have to be. All of them are available to be put on the COVAX once they have WHO EUL. but not all manufacturers may choose to enter into an agreement with COVAX.
Senator.
Thank you, Chair. Good morning again, and thank you again for the presentation. My focus is on trying to address the burden in the hospitals and the death rates and the inundation that we're seeing there. And I go back to, and I can supply the information around vitamin C. More and more research is coming out confirming its effectiveness. One of the most successful countries in managing the COVID crisis has been New Zealand. That is one of the agents that they have used in their treatment protocols. Same thing in New York, as I mentioned before. As I said, if you go on PubMed, you will find a lot of information confirming this. Now, relating this now to our current situation, what I noticed was, and I'm curious about, the 6 deaths, or the 1% within the younger age group that died, what possibly could have been associated with those deaths. And I also now reflect on the fact that we're seeing higher death rates among the lower socioeconomic groups. So I wonder, one of the things that is affected by our economy and our ability to purchase is our diet, is our food. So I go back to saying, can we review the clinical protocols that maybe that group of individuals may benefit from vitamin C being applied to their protocols? It is about trying to save these lives. I also would like to know, in terms of the elderly group and the elderly recovered, how many had comorbidities? So the elderly group and those who did not succumb, what was their health status? Because I am trying to do this because I have a lot of elderly persons who are coming to me asking whether or not they should go for the vaccine. And the way I decided is to say, okay, it's a risk versus benefit analysis. I say to them, look, you have to consider, if you get COVID, what is your likelihood of survival versus if you take the vaccine and you have concerns around it, what is your likelihood of succumbing or being victim to those complications? So I asked that question in terms of the healthy elderly and their need to take the vaccine. The last other question that I have is kind of related to the vaccine doses and the healthcare workers. A number of healthcare workers have had COVID, are recovering from COVID, etc. Would they need a second dose? A lot of research is showing that the persons who have had COVID have a natural immune response and may not need a second dose. That would add to your supply if they might not be needed. And lastly, in conjunction with Senator Rodriguez's concern with the crowding, can something be done about the crowding at the clinics, in the hospitals, where the comorbid conditions are being treated and you're seeing persons waiting for their appointments and there are crowds gathering? Maybe some tents, maybe some enforcement of social distancing, because especially that population would be vulnerable to transmission. Thank you.
Okay, who wants to take that? Dr. Williams?
Good morning, Senator. Thanks for the question. With respect to vitamin C, there is an inclusion of vitamin C in our protocols, actually, to say that
I was trying to find the protocol. I was actually here on the ministry website trying to find it, but I didn't see it. So,
well, it is listed as one of the measures that we are not rejecting, and so it is listed among other elements that will enhance our immune system. So there are many different things that people will do, and so it is not to say, because we do know that many studies have in fact looked at a number of vitamins, vitamin C, vitamin D, and zinc, as potential suggestions, but not to say, because the evidence is still a little bit iffy with respect to, the absolute impact
Williams,
that the inclusion is going to have, but it is included in the protocol.
What I would really hope to see is that this information is being conveyed, especially to the persons who are vulnerable. So the lower socioeconomic groups where we're seeing the higher death rates are probably the persons who are not able to afford this type of approach of immune boosting. So perhaps that information, that dissemination could be facilitated, especially in those socioeconomic groups.
I do know that we have said, boost the immune system, and that has been, proposed. So perhaps we do need to say to persons, just boost your immune system. But I do know, for example, that in some facilities, that vitamin C is actually utilized for this purpose.
Okay. You have one final response? CMO?
You asked about the deaths in the 6 persons who are younger than the usual age group. I am not totally, I think that it needs further investigation, but certainly persons who are younger still, they may have pre-diagnosed comorbidities, and particularly with respect to why it is that persons actually die, there may be other issues that are hereto unknown. So I'm not really in a position to speak to that in its entirety right now. Not sure. No. Further investigations will be needed, CMO?
Yeah, certainly within every kind of cohort that is investigated, there are always going to be outliers. I think the important thing is to have recognized that there are risk factors for some persons, and to be able to target those groups in terms of our education and in terms of how it is that we prevent them. So I am sure that there are unidentified risk factors still that may affect or could have affected those 6 persons. And the investigations and the research is ongoing. These deaths would have to be looked at clearly. But you're always going to find some people that just don't fit. Yeah. And you just have to keep questioning. But it's 6. If it was 50% of persons that did not fit, then that would be a big issue, because clearly there would be a large unrecognized factor that we are not seeing.
As you mentioned that, CMO, I just remembered that I've been hearing anecdotally, and persons who have had COVID have said to me the use of aspirin and the coagulation issues, etc. And quite a few persons who I know personally have said that they started to have a chest tightness and the left arm issues, etc. And basically the aspirin relieves such, etc. So just something to say, we know that aspirin is part of some protocols, and perhaps we could also look at that. Because maybe that may be some of the sudden deaths that we're seeing.
Right.
Okay, so can we move on now, please?
Sure.
And let's take Member Brown-Burke, and then we'll come to you, Senator.
Okay, thank you very much, Minister. And I hope I'm being heard with my mask on. Yes? Okay, thank you very much. There are a couple of things I want to say. I want to first thank the team and all that they have been doing, and the kind of sacrifices that we have seen and we know to be happening. And I want to also remind us, even as I say that many individuals who have concerns legitimately, because we are talking about life and death. We are talking about unusual times and something that we are not used to. So when issues arise and people ask questions, I want us to be very careful not to even suggest for half a second that people are creating mischief around issues that they are concerned about. And I think it is important in terms of ensuring that we maintain the kind of collaboration that is required. And in saying that, the sub-prioritization that the PS outlined, I think is welcome. I know a lot of persons have been talking about a tiered approach that we have seen elsewhere. and that persons were concerned, given the fact that we have limited supply, about how that was working. So I'm pleased to see that today. So two questions. One is, when we talk about the parish health authority that persons can go to, who probably don't have phones, can't access website, exactly what is that? Just so that persons are very clear in their mind what we're talking about. Secondly, it's not just a tax office that needs to be looked at. A number of government offices are a real problem. A number of them. Whether it is to get your police record, a number of them. Forget about post office when it's time to pay your NIS or your PATH benefits. And I believe that we have to find a way to ensure that the conditions that exist there don't continue. So I want to make sure that that is so. And then just a very simple question. Given some of what has happened before, what are some of the lessons learned? And is there a process of verification as we roll out the other groups that we're talking about? And I'm pleased not just to hear about the sub-prioritization, but to also see it there and ahead of time. Because sometimes that's how we treat information, and we seem to be guarding it so closely, raises concerns. Those are my questions. Thank you very much.
Thank you, Member. And just to say, as I welcome your questions, that there is no intention of muzzling anyone, and we appreciate all questions. And the intention is just to provide clarity in terms of the response. So whether in tone or style, please take no offense to the responses. It's all meant in good spirit. All right, so PS, you want to go first and then?
So thank you, Chairman, and thank you, Member. The registration process, especially for the elderly, is something that has, last night it took up a good 2 hours of conversation, because there's always a question of equity and access. So if I put something on a website, or I say call a number, I do create an issue of equity for those who don't have access to call and don't have access to internet, to go on the internet. And so we are looking at different mechanisms. So right now we have our registers within our health facilities of persons who are diabetic, hypertensive, or chronic disease registers. The public health officers are willing to engage these registers to make sure that those persons who are 75 and over on those registers are taken care of in this phase or sub-phase of the operation. And there are other, as Dr. Ennis pointed out, those persons who are homebound cannot access the way in which we have to use our public health, our public community health aides who know these homebound persons in communities to generate the necessary line lists to reach the full gamut of the population. So we are contemplating all the avenues. I mean, I was pilloried by the medical officers of health last night when I told them that they cannot engage on the system. They were like, no, if the private doctors can engage, we must be able to be engaged as well, because we have patients just as the private doctors have patients. So we are continuing the conversation, and we will ensure the principle of equity, which is one of the foundation on which the vaccination program is anchored, is maintained.
Was there a question for you, CMO?
No, the other question on the different, so we are in conversations with the different ministries, departments, and agencies that deal with high volumes of persons who need to be seen, and to see how we can streamline their operation to reduce risk factors of crowding, especially for infectious disease like COVID.
Okay, this time is now 12. Okay.
So the senator had asked a question concerning the second dose of vaccine in persons who would have had COVID before. So there is ongoing discussion about that. Right now, the guidance is that we want persons to develop adequate immunity. And so it is 2 doses that is still being recommended for persons, even though they have had the COVID, because we're not sure that what is the level of immunity. So right now, the guidance may change, but right now, we're sticking with that.
And the healthy elderly, you had also asked about the healthy elderly getting the vaccine. Yes, they are also to be offered the vaccine, but of course, their phase will be a little later than those with comorbidities.
Thank you. All right, Senator, you want to ask your questions? Folks, it's 12:11. I want to complete this process the latest 12:30. So that would make it exactly 2 hours, the meeting that is. Go ahead, Senator.
Thank you very much, Chair. I just have a clarification for the PS. I believe you had mentioned about the concerns with wastage and just being very efficient with the use of the vaccines. Do we yet at this stage have any reports of waste based on what we've seen over the last 4 or 5 days?
Thank you very much for that question. Yes, we have 2 reports of wastage. One is for 8 doses that fell from a table in the West, and the other, yes, the table collapsed and the vial broke. It had 8 doses in it. And there's another report of 6 doses. It was being held in someone's hand and it slipped out. So we have 8 and 6 are the ones that I have received reports for as being wasted doses.
But the audit would complete that process, I would imagine, right? So there's an audit. The audit that we mentioned would also account for how the doses have been used and if there's any waste. Incidentally, there is normally a benchmark standard of about 5% waste, I am told. So let's hope we don't have that because supplies are limited.
That is absolutely correct as well, but we should also bear in mind the fact that in the vials that we have been opening, we are noticing that we're getting 11 and 12 full doses out of the vials. So we have been vaccinating more than 10 persons. So that kind of compensates for the loss that we have seen. So it's 11 doses on average that we're getting out of each vial at this time.
Okay. Well, that's good. I'll take 2 more questions and then we'll close out. No question from your member? No? Okay. So, member, you will be able to ask your 12th and 13th question.
Yes, it's actually on the
and
AOB.
not too much beyond that.
On the AOB, so it's not
on the AOB. Well,
yes.
Before you get to AOB, if we're completed, and I appreciate the efficiency of time usage, I wanted to go through a procedural matter. And I want to first of all thank the members for, but don't leave, just thanking you for what you have done, the presentation so far. I wanted to conclude on the quorum for this committee. We did not handle that in the early stages. I'm proposing that we could do 4, which includes the chair. Is that acceptable? Normally, that's a sort of normal practice.
5.
The committee has 11 members. I think 4 would be a reasonable quorum.
I would recommend 4 plus the chair.
4 plus, not 4 including.
No, 4 plus.
So
5 inclusive of the chair.
Okay, that's fine. All right, so can someone just move that motion?
So moved, Chairman.
Moved by Member Guy, seconded by Senator Campbell Rodriguez. All right, excellent. So we'll make it then 4 plus the chair. All right, on any other business, Member Guy, you can now proceed.
Chairman, just a concern that not only I have, but others have. Why is it that it's only 2 antigen test kits that are only being approved by the Ministry of Health for utilization now? which
The
is
antigen tests
SD,
that have been approved for use. Remember, he's asking why
Abbott
is it that
and
we
the
only...
SD. Why are not others that are just as equally effective, that have been utilized a lot, say in the States and in the UK, not been approved by the ministry for utilization by the respective laboratories?
I thought we're at 3 now, but go ahead. Zero.
Right, so it is 3. We've added the Abbott. I will follow up on this.
What's the third one, CMO? What's the third one?
It's an Abbott.
No. So what were the other 2?
There were 2 SD biosensors.
Oh.
2 different types, and then there's the Abbott. But I will follow up on this because we did identify. We looked at those that were approved by the FDA, and there were 3 that were possibly because of the lateral flow rather than using the machine. So there were 3 that could be utilized easily. 1 was already there, the Abbott, and so there were 2 others that we were supposed to be following up on. So I will follow up on this with our lab to see what exactly. I really have not followed up on it, so I will. Okay.
And I want to say that I share that concern. I think we need to find a few more reliable tests because, you know, the demand is great, but I do take the point from the technical team that they need to be assured that those tests are in fact as reliable as possible. Okay, so I will now move to item 9, which is a date for the next meeting. We had said twice a month, so could we go there, not next week, but the week after? What date is that? 31st, that's not Wednesday. Oh, Wednesday the 31st at 10 a.m. Can we make a note of that? And also, I'm going to ask that we want to invite Mr. Christopher Zaka of the Sagicor/private sector to appear on that date. So we want to give him ample notice for his appearance to speak to the private-public partnership. Okay, so the 31st, we will meet. We will take that as a priority presentation as well as a general update as we normally do. No, we apparently Tuesdays had other meetings in the regular calendar, which is PAC. So there's a clash. So we had said, if not Tuesdays, we do on Wednesdays. All right, so I want to take the opportunity to thank members for attending and participating. Thank the team from the Ministry of Health and Wellness. The full A team came out this morning, so we had a good contingent of presenters and experts and otherwise, so we appreciate that. Okay, so next meeting, the 31st, 10 a.m. Can I get a motion? So move, Senator. Second, Senator. Thank you very much. Meeting is adjourned, and I'll use my hand since I don't have the...